TopMedTalk.
Welcome to TopMedTalk. We are here in Atlanta at the inaugural meeting for EBPOM USA 2018, Evidence-Based Perioperative Medicine. I am Desiree Chappell, your co-host of the Roundtable on TopMedTalk. I'm joined here with Monty Mythen, co-host of TopMedTalk as well, and we're also joined today by Dr. Lee Fleisher. He's the chair of anesthesiology for University of Pennsylvania. And Vicki Morton, she is a DNP and the director of clinical and quality outcomes at Providence Anesthesia in Charlotte, North Carolina. Thank you both for joining us this afternoon.
Pleasure.
Thank you for having me.
Great sessions today. Lee, you presented earlier in the day, and some great information to share, more dealing with policy and what's going on here on the ground in the U.S. as far as how we are trying to navigate the system and transition, I guess, into value-based care and using different quality measures and things like that in care. And I know, Monty, we've talked a little bit about you had some great questions regarding some of that. So do you want to kind of kick off with a good question for Lee?
Thank you very much indeed. To echo the fact, really great first session today. Lots
really
of energy in the room. First session's talking about these really big issues, the challenge we have with healthcare delivery, which also always loops back to, is it going to be affordable going forward? And Lee, I think you told us that the prediction at the moment in the USA that the spend of GDP on healthcare, and we'll come back in a moment to what we mean by healthcare. If I wrote it down correctly, it's currently 17.9% and it's predicted to go to 19.7%, with the assumption that the GDP stays roughly where it is at the moment. But that's one of the uncontrolled variables. Is that right?
So they expect the rate of rise in GDP to be lower than the rate of rise of cost of healthcare delivery. So, and that's the differential. So that's why it will be a higher percentage over the next decade.
So it's going to get harder and harder to balance the books.
Correct. Or it's going to get harder and harder for patients to afford to have, entertainment, food, etc.
But the GDP could go up a lot.
And they're predicting it rise. I think it's maybe 3%, and if it's higher, that's great. But they think healthcare spend is 1% per year more over the next decade than the GDP rise.
Now, when we look at the OECD curves, in other words, the group of countries that are usually on those graphs, everyone's graphs are going the same way, but then they're separated quite a lot. And we've spent a long time saying how much you'll spend on healthcare in the USA, and we often quote it somewhere around that 18 to 20%. And in the UK, we think we spend a lot less because we think we spend about 8 to 9% of GDP. But you showed a graph in your presentation where the USA was not at one end of the overall spend. It started, I think, with France, then Belgium, then Denmark. But that graph was both health spend and social services, which I hadn't really got my head around before. Can you expand on that?
So what they're saying is if we add in schools, how much people pay for schools, transportation, food, underlying infrastructure for the poor, so our infrastructure to make sure that the poor can be sustainable. If you add those two figures together, then look across the developed world, then you've got this other curve where we're right in the middle.
Yeah.
The problem is we are different than every other country in that we don't spend that much like you do in the UK or Denmark or other places on that infrastructure, making sure the social services are good. We spend it all on hospitals and doctors and drugs and devices.
So you're spending it on fixing the things that are broke that might not have got broke if you had transport and education and all those other things. Is it that simple? It can't be that simple, is it?
Well, it assumes that a lot of what is driving the comorbidities, the poor health in our country, could be fixed by better schools, better education, better transportation. That's a big assumption. It probably, some degree, absolutely true. So I don't think we could transition all of it, because part of this is, there's these articles, it's all about the prices, and part of it is Americans are used to demanding their level of health care in my own hospital. I'm being slightly overdramatic, but nobody would die in our heart and vascular ICU without going on ECMO. I'm sure that wouldn't happen in the UK.
No.
It's not about death panels, but here the expectation is we're going to do everything. So I think some of this has to be a change in our expectations. But if we did spend more on social services, it's clear to most people that we would spend less on health care.
Desiree, I'm sorry, you're chairing us here, but you were one of the presenters, so therefore I think it's fair to push a question back to you. And in your presentation, you presented some of the common causes of death in the USA. Can you remind us of those? In other words, it related to things like diet and smoking and...
Yes, the obesity problem that is always thought to be exclusive to Kentucky, but apparently it's a worldwide problem. And smoking can cause major issues, and it still is a major concern for us in the state of Kentucky as well. And
the opioid epidemic is a little more unique to the U.S. than other places.
Yeah, and actually in the state of Kentucky, as I mentioned before, we're in the top 3 in the U.S. for drug overdoses currently, and causing a true healthcare issue and crisis within the state.
So is that from homelessness to some extent? I mean, some extent it's just...
No, I think, just looking back at our patients that we take care of that are overdose patients or those that are having complications due to drug use, it spans the spectrum of patients. It's not limited to the impoverished. I mean, we have good kids coming in that
soccer moms.
Yeah, soccer moms, exactly, stay-at-home moms. That are all struggling with this addiction, and where that comes from. And we've had a lot of discussion about that around the opioid crisis and where it actually starts. And 6 to 8%, I think, have been some of the numbers thrown out that can start from pain and surgical pain, and when those people were prescribed opioids. And so, I mean, it really is a critical mass. And
so Monty, and I'm curious, Vicki, in your roles, we've been spending a lot of time trying to fix how many pills people go home on. In the UK, did you have the same phenomenon that we did where our orthopedic surgeons will send people home with 60 days worth of pills and they
not to the same extent? Part of that is because we always have the breaks. Any savings we can find, we're going to be very mean with it. Part of that is let's not send people out with too many drugs that we don't need to send them out with. We know where they end up. So part of it is an appropriate meanness with the resource. But the other thing is a very ready access to primary care and very ready access to support from pharmacy. So if you do go out with 3 days of pain meds, if you need a 4th day, it's not hard to sort it out. And people here keep telling me that's hard in a way I can't get my head around. What is it that's hard about finding day 4 and 5 of pain meds?
No, I completely agree with you, Monty. But some of the conversations that I've had with our surgeons, if a patient calls and it's day 4, 10 o'clock at night, they have to be sent to the emergency room because they cannot get a prescription, right? Yeah. However, the approach is shifting somewhat, at least in our facilities. When you talk about the amount of drugs going out the door, we recently started looking at, the fact that 52% of our patients do not receive an opioid on the floor. And they may not receive anything in PACU either, but we're still sending all of them home with 5 days of oxycodone. So we've started shifting and educating the patients to really continue acetaminophen, nonsteroidals when they go home, and not give them those prescriptions. It's slow to adopt, but it's starting to happen.
Well, and the transition is coming from, for us personally, and what I am kind of hearing across the U.S. is, establishing that with your patients preoperatively and talking to them about what the expectation is. And we now are having patients saying, no, we don't want to go home with any narcotics. We'll let you know if we need anything. And so I think that that's going to be one of our biggest ways to target that. And another kind of anecdotal thing, talking about sending narcotics home, we had one surgeon who was very passionate about, once he saw the benefits of multimodal pain management and, reducing the amount of narcotics in the hospital, he's like, I'm going to stop sending narcotics home with my patients. And I asked him just recently, do you feel like you get more phone calls? Has this really created a problem for you? And he's like, no, absolutely not. He's like, I actually get less phone calls now than I did before, and I'm not sending narcotics home with my patients.
So we actually are using behavioral economics to change the way surgeons operate, in that if you go into Epic, our electronic health record, the default is you send people home with 10 pills. So it's not 5 days. It's actually, you have to work to send people home with even more pills. So thinking about defaults is important.
And that's often there, is it? In other words, it's just pushed into the system somehow.
Yes.
And therefore it's hard to unpick it. But the crisis point is here to unpick it, isn't it?
Yes.
Oh, yeah, absolutely.
That's good.
And in fact, it's interesting. There's a New York Times letter to the editor about a woman in Germany. Did you see this article that talked about that they told her in Germany that she should go home and have tea rather than needing narcotics after her surgical procedure? And it was very hard to interpret whether she was happy that she was pushed, that all they need is tea and rest and walking,
Sounds
or
very
quite
British.
upset. But it's really becoming education, which is so much
really
part of ERAS.
Mm-hmm.
It's interesting to me, and I think about, going to Nigeria, and have done that a few times to do total joint replacement, hips and knees. And all the patients get acetaminophen, nonsteroidals after surgery, and they are perfectly happy. Yeah. They are good.
So if I may ask another question of Lee, because I wrote a whole load of notes down here. They're things that I'm sure you all understand, but they don't completely make sense to me. Maryland.
Yes.
We've heard of Maryland in the UK because I think it was one of those early places where the Brits were allowed in for a while.
Okay.
And that's why it was called Maryland. But the Maryland healthcare experiment, which you highlighted for us brilliantly, but I think if we could share it to a broader audience, that would be great.
So Maryland, which they have two academic medical centers, but the most famous being Johns Hopkins, as well as the University of Maryland, has for decades had an experiment in which all the payers agreed to pay the same price for a hospital room, and that the hospitals essentially would be held harmless in that they couldn't make too much money, but they couldn't lose too much because they would adjust the price that the insurers would pay based upon the needs. So when they came into this value-based health care, they actually negotiated with Medicare to do an all-payer transition to getting a global budget before the year starts. And that budget would be based upon the number of patients that are assigned to your hospital. Okay. And you had to figure out how to deliver all care.
So I think that's where we are in the UK. So I think we get a capitation fee for your population. They
Correct.
say, there's a chunk of change, get on with it, now make it work, which is, we're not saying it's perfect in any way, shape or form, but you've got some control over spend, resource, how to best use it. So that's unique in the USA, is it?
That is unique for that state, but there's some outs here. And the outs are a couple-fold. One is if you get international patients or patients from other states, you can charge whatever you want and make the money. The second one is that, and this is very relevant for the Hopkins of the world, if you do unique things like transplants, it's incredibly expensive. So I'd be curious in the UK, do they regionalize it? Because depending on what you do for the patient can cost you a lot more.
Yeah, there are special tariffs. So certain categories, transplant would be an example, very unusual surgeries. There are national tariffs that then get moved around, so you bid for them to do a number of transplants per annum. But it's separate from that capitated fee for doing the every day of the week joint replacements, the regular cancer surgeries, etc.
So we're still trying to figure it out. In Maryland, the issue is that in 2019, the previous administration, so we'll see what will happen, actually said not only are you going to be responsible for the spend of the hospital, but you'll be responsible for the spend of the doctors for those same capitated patients. So the issue is those doctors don't necessarily work for the hospital.
Okay.
That's what I was going to just ask. I mean, how are your providers play a role in this, and how are they kind of getting paid? I mean, it's a very general question.
And they get paid the old-fashioned way, but the hospital's on the hook that they could lose money because your providers attached to those patients will be spending more. So this is really trying to align us very similar to the British system.
How much are the hospital systems pushing to bring those surgeons on board as part of as being hospital employees versus private groups?
I think they're trying to figure it out depending on the hospital and who is and the primary care providers, which are probably even more important than the surgeons. And that's the interesting experiment, because in the U.S., what's happening is consolidation. So we've got all these big systems buying up other hospitals, and how can they work together? So it's a grand experiment. It would save a lot of money for our system if we went there, but everybody's watching Maryland because it's the only state that has this.
Are they sharing savings? So are they able to do that on the other side? If the surgeon does, everything that they're supposed to do, follow all the protocols and standards, and they actually save money, or is that something that's going back?
It depends on the system. I know a little bit about Hopkins, having been there, and they're still trying to figure it out. But they, I will tell you, at Penn, we actually have that. If we have savings on a service line, we share it back with the docs. But there are some anti-competition laws, Stark laws about self-referral, et cetera, that we have to get around to see whether or not we can share some of those savings.
We know incentivizing sometimes is a good way to get people on board.
Yes.
So I have a question. We recently went through a situation where the insurance provider, because with our bariatric program we were doing so well and saving so much money, they reduced our reimbursements by $400,000. That was not an outcome I was ever expecting to happen. And I'd like to know what your thoughts are on that.
So that is an outcome I expect to happen, because we have to bend the cost curve. So you almost have to go in with the question, because the other thing they can do is just switch it to an outpatient procedure.
And we are.
And you are. And then every time you renegotiate, you can negotiate a new fee. And we have this with the hospital, and I do a lot of our negotiations for our system. So you really have to make them understand in the negotiations that if they get too aggressive at dropping the payment, there's going to be no incentive for innovation. So that's the key, is making them understand that we want to bend the cost curve. If we can get it down, that's great. But if you get too draconian in how you pay, there will be no more innovation.
Right.
And that's a recurring discussion in our system. You have to maintain that the salaries, the quality of staff, you have to have an irreducible minimum. You have to keep something in the system that funds innovation, or it all gets completely stifled. It becomes commoditized, and that's a downward spiral, I think.
What other industry only spends 1% to 2% or less on innovation? Apple doesn't. The drug companies don't. And, we think a lot about radiology. I mean, I actually think they're a group that as we get better, we're going to need less radiologists, and we're going to need less post-acute care. Do we give them a soft landing? Do we actually say to our radiologists, we're going to pay you to work less, and in 5 years we want, as people retire, just don't replace them?
Because I'm guessing that the computers can do the radiology interpretation pretty damn well if we let them get on with it, with a bit of AI support.
It's not about that. It's actually, do you need as many X-rays? I mean, that's on the pre-op clinics and the post-op.
No, it's true. Yeah, I mean, you're just assessing patients more aggressively and not just doing a blanket order for every single patient. I mean, you need to assess whether or not they truly need it.
We don't have a pre-op clinic.
Oh.
Our physician, our surgeons probably over-order tests.
Yeah.
So before we move on from Maryland, one thing you didn't say is whether, if there's a league table of results, are they mid-table, bottom of the table, top of the table? You know, if they've got this system and it sounds sensible economically, are the outcomes better or worse?
They started out not quite as good.
Okay.
And they're getting into, I think, the average range, but they're still studying it.
Okay. Okay.
Interesting.
Is it a good model for the rest of the country, you think?
I actually think the waiver of the doctors are not yet aligned with the health systems. I think, is it a good model for the UK?
It's like all of these things, you know, we seem to be spending relatively little money compared to the USA on healthcare, and our outcomes appear to be a lot better overall. And a part of that may be the distribution of our social services spend compared to the health spend. Part of that may be because people in the food chain are paid a lot less money. Who knows? But you know, even if you look at the very crude metrics of live births per 100,000, or whether overall length of life is going up or down, big picture is we seem to be doing all right.
But you probably use less resources.
Yeah.
And the question is, how quickly can we get people to realize that, you know, not doing something is okay?
Right.
We're not there yet.
So on that, you touched on the bundles, which is the concept of the bundle payment is one of the ways that's thought to get a bit of a control on that. In other words, you're going to get this chunk of change for doing a particular type of procedure, work within that bundle of money,
right,
and see if you can get a margin out of that. How's that all going?
That is the only thing that's been shown to save money.
Okay.
You have to have outliers. Several years ago, we had the most expensive hip replacement in the U.S. because we had a hemophiliac. And it was $1 million worth of products. So you have to... Now, fortunately, my visiting professor that week was Patrick Conway, who was the CMO of CMS, and we had a good talk. But the bundles really do provide an excellent opportunity to have savings. The interesting question is they start with the assumption you need surgery. So let's talk about back pain, and I've actually been talking to CMS. Wouldn't it be interesting for the anesthesia department with PM&R and others, to start with a symptom rather than we're definitely undergoing surgery?
I thought you did. Can't you get a bundled payment for back pain as opposed to a bundled payment for back surgery?
No, it's starting right now with surgery. People are proposing. And the problem is that they haven't figured out how to pay for it.
Aren't some people doing that with joints now, too?
They're starting, but it's more population health rather than joint pain. So starting, if you rehab them and you get them to stay away from the surgeon for a couple of years, is that advantageous?
So just so I'm clear, at the moment the bundle tends to be for having a joint replacement.
Correct.
And the opposite argument would be that there's a bundled payment to make the pain right for the patient and to make their quality of life better, which may or may not involve the joint replacement. Have I
Correct.
My head? Okay.
And it would be great to get to that second place, and then anesthesiologists should get a larger piece, or PM&R, whoever are the right group, behavioral health.
Mm-hmm.
I mean,
whoever can fix the problem.
Yeah.
And you talked about it there in part of the change that's happening is that there are opt-in bundles. Now, listening across the pond with all the changes in healthcare and people pushing back against the bundled concept, you get the impression that everyone would be running away from bundles. Whereas the opt-in would imply the fact that there's, for some people, it's a win-win.
Correct. So the interesting thing is that the opt-in, as part of the opt-in, you get your own data.
Okay.
Because the problem in the U.S. is if it's a Medicare patient and they're not coming back to our own hospital, or they're going to a post-acute rehab facility that we don't pay for, we don't know our total cost, our total spend. So a lot of people are asking, they say, we're going to pilot or ask to get the data. If the data looks good, then they may opt in and actually do the bundle.
Got you. I think I'm getting a handle on that now. So Medicare, Medicaid is the government, the tax spend on healthcare. So at the moment, you do the joint replacement outside of a bundle, then you may send somebody to these things called post-acute care facilities that are rehab, but residential rehab. So you're still in sort of hospital, but you don't call it a hospital.
Right.
And Medicare are paying for that, but you don't get to see the spend, so you don't know what happens. Okay, I've got that.
Or they go back to a hospital that's not your hospital.
Right. So if you were to accept the bundle, you'd take responsibility for getting them home, and if you're good at that, you can keep the margin.
Correct. But staying home.
Staying home. So stay home. And when does the window of responsibility stop?
So in many of them, they're 30 days, but I've just been asked to sit on a panel that's a 90-day bundle for cardiac surgery. So my suspicion is we are going to 90 days.
Well, that's an extended period of time, especially for a cardiovascular patient. Yeah,
So I don't have a pre-op clinic, so I'm curious what in your centers, how your anesthesiologists and nurse anesthetists and DNPs and others are thinking through keeping them out of the hospital from pre-op stuff or post-op.
Well, both. So we're actually in the process right now, and one of the reasons that we're here to better learn how to work a pre-op clinic, patient optimization, because we've got great clinics to be seen, or patients to be seen in, and do the normal testing and what have you. And we see every single one of our enhanced recovery patients in those clinics, but the other patients are screened, and if they meet certain criteria, will come in. But what we need to work on is, okay, we have a patient that's come in, has uncontrolled blood sugars. What do we do? And essentially, not much. We maybe refer them back to their primary care, what have you. And so we're really trying to work harder to get these patients in better condition going into surgery.
So, Lee, when you scrapped your preoperative clinic, you had one, did you? And then it
Before I got to Penn.
Okay.
The health system scrapped it.
Right. So was that because the clinic was a place you went to have your problems documented, as opposed to a place where you went to have your problems fixed?
My assumption is
okay.
The prior, documented. And at that time, the issue was cancellations. Everyone talks about cancellation rates being the primary reason to have a pre-op clinic. What I have been learning from you, and as well as everyone on this panel, is the world has changed. We should do fewer patients, but actually put them in the optimal condition, because the key thing about the bundles is it's the readmission for any cause.
Okay, well, I'm really getting a handle on this now. So, Vicki, I think what you're telling me is you're refashioning your pre-op clinics to not document the people who are well, but to fix the people who need fixing, and put all your energy into that.
Correct.
We're actually not doing separate clinics. I mean, like kind of what we're talking about, diabetes or anemia. It's all wrapped up into one. And when we first started Enhanced Recovery, and actually even before then, it was about optimization and getting a hold of that patient before they got to surgery, so we could fix at least, if we had a diabetic, and trying a little bit better control over that, or if they had anemia or they had cardiovascular issues, we could send the patient and kind of try and figure out ways in which we could go ahead and treat the issue or optimize them before they got to surgery. But one of the things that we've since started in our cardiac ERAS program is nutritional optimization, and some other things that we are trying to, on the front end, prevent readmissions on the back end as well.
So I'm curious, Desiree, because it's one thing to optimize them to get them through surgery.
True.
It's another, which is what I'm hearing you guys doing, and what I'm trying to convince my own center they should do, is optimize them, period.
Right.
To get them through life.
Right.
Yes.
Not to have surgery.
And it'll last 30 days to 90 days.
Yeah.
Is that...
Right. Yeah.
I mean, I wrote some of these guidelines. It was always, can you get them to 90, out of the hospital?
Yeah. I mean, it's the conversation that we're having and trying to move in that direction. And I think that everyone's kind of...
I mean, if you fix anemia, you fix pre-diabetes, you stop people smoking, you help their sleep apnea. If they never have surgery, that's not wasted effort, is it? That's good medicine. That's population health.
But then you do have less surgeries, potentially, and then you have potentially a group of individuals that
like a
may
hospital.
not. Yeah.
So
It's
So
got to
what's
change, isn't it? It's got
So-
to
I mean,
change.
it's a
So
transition.
the problem is that we're in this world where, and Vicki and I had a great discussion, where many hospitals are still making their money in fee-for-service.
Yeah.
So they don't want us to cancel cases. They don't want less surgery, although they don't want bad outcomes, really bad outcomes. So the question, I have is, how do you start the conversation today to say, if you are looking better, and I understand your hospital's looking better, how do you support us increasingly? Because if not, why should we do this and lose money? You don't have to necessarily gain, but you can't lose.
Right. Yeah, I mean, those are conversations that there have been many with administration, and it's, continually just going over the cost savings, the financial analysis, talking about what's best for the patient, the whole thing. And eventually, I mean, I'm really fortunate where I work, and even though I work for an anesthesia group, we have a fantastic partnership with our hospital system and great team of collaborative individuals, and they do see the benefit, and I think they are willing.
But why aren't they paying for part of you?
I think that's, again, I've been in this role now just over a year, and
Okay.
and really when I came in, the program was very small, and now it's huge, and 6-7 hospitals participating. They're getting it, and they've made it a corporate initiative, and they're coming around with that.
So like many hospitals, we have an ERAS collaborative that's a surgeon and anesthesiologist are running, and I've already started socializing with the system that it is very expensive to not have them in the OR. I'll pay for it today, but there's going to be a point in time.
I mean, one of the points I made during my presentation today is that going forward, we have to start changing the narrative. I mean, when ERAS first came and we were trying to, it's all about length of stay, it's all about cost savings. We're still in a fee-for-service world. That's the reality right now. And so that's not the narrative that you need to have with, key stakeholders. It needs to be some of these other issues. And
Won't ultimately patient power the consumer, the customer, get a grip on all of this? Won't that be the ultimate conclusion to the whole thing? You mentioned, Lee, that if we at any stage see PBPM, I think I wrote down here, written down some, we should
beneficiary per month.
Per beneficiary per month. Is
So
that got anything to do with controlling these things?
So that essentially is how you pay for population health, is that they give the gatekeeper, so to speak, the primary care, the hospital, extra money to keep them healthy. And now they're going to see if it's worth it. It's like $2 per month. But the hope is to experiment and see, to pay for care coordinators, to pay for Vicki.
But $2 per month for the population you look after.
Right.
So if you've got, just to put it simple, you've got millions of healthy people, that's good business. You can make those $2.
It's risk adjusted.
Yeah, but you can make those $2 per month go a long way. That's a lot of dollars.
Correct.
But that's an ongoing experiment. It's a bit like Maryland and opting into bundles.
Yes. So, for example, we have, we take care of millions of patients at Penn, but we're responsible for 100,000 lives.
Right.
That's it.
Yeah.
Not the millions that come through our doors.
And I've got one last, if I may, Desiree.
all right.
I wrote down here, MedPAC votes 14-2 to junk MIPS. What does that mean?
So, Congress set up an independent body to advise them on payment. It's called MedPAC, the Medicare Payment Advisory Committee. So, for the U.S. listeners, we had a formula to decide how doctors would be paid that had a fatal flaw in it, that essentially caused every year for doctors to be paid less and less till it got to 21% cut,
Right.
which nobody would accept. So every 6 months, they said, we'll fix it, but for 6 months. So finally they said, we will fix it for good because things were going so well. They thought they could spend the amount of money it would cost to permanently fix it. But in exchange, the physician groups had to give up something, and that was being more responsible in the quality domain. So that was MACRA.
And what's MACRA?
MACRA
sounds like an online shopping thing. No,
it's
or a supermarket from.
Because
macro,
you asked me.
Yeah.
It's an acronym for the law.
Okay, the law. So
for the law that fixed the reform that fixed that was the doctor fix.
Okay.
And MIPS, which is the Measurement Incentive Program, that essentially was inside MACRA that said we are going to pay doctors a higher and higher percent on value based on measuring you and seeing if you've done well. So the problem is...
So junked that? They said they don't like the idea that you incentivize high-quality care?
So the problem is that we had hoped that the measurement would be tied to what the doctors do.
Okay.
But the way we do this is based upon the tax ID number of the group. So if I'm at Penn, I am part of 18 departments.
Right.
So as long as I do any measures relevant to any of the 18 departments, which could be family medicine and internal medicine, that I don't have to measure anesthesia outcomes. All I have to do is measure something within those 18 departments. So the surgeons were not measured for surgical outcomes. On top of that, if you don't do enough Medicare cases, you don't have to actually submit. On top of that, if you're in alternative payment models, you don't have to submit. So it's not that they don't think incentives make a difference. It's they think that the way they implemented the program has such problems. Essentially, they're not getting the outcome they want. They still think incentives are important. It's more the way they implemented it.
And quality of care is, of course, important.
Yeah.
So what's it been replaced by?
Nothing yet.
Okay.
It's still intact. So this is not Congress.
No.
Actually,
right,
did it.
It was a group of surgeons. All right. Well, Dr. Fleisher, Vicki, Monty, thank you so much for joining us at the end of day one. And end of day one of EBPOM. Any final thoughts, Lee, for today?
No, it was a fantastic meeting, and the exciting part about EBPOM is that we're really driving quality of care for patients, and the exciting thing is our panel started with the patient and the way the British did approached it, and my talk was really in that system. How can you use different payment models to afford to make that change? Not how do we go after payment and then follow it with patients. And I think that's the right order.
Yeah.
It's all about the patient, isn't it?
If we do the right thing.
Yeah.
We're doing the right thing. We're winning.
And we will be paid well if we can articulate how we made the patient and the system win.
Patient power.
There you go.
I
All
like
right.
it.
Well, I think we're going to end there. I think that's the best way to end today. Gentlemen, ladies, thank you so much. And we'll see you tomorrow at EBPOM USA 2018 in Atlanta.
TopMedTalk.